Thank you for the introduction. My name is Neyla. I'm a resident at McGill University. I have no disclosures personally, but these are the disclosures of my co-authors. Hartmann's procedure was initially described by Henry Hartmann in 1921, and we're still using it 100 years later. It consists of 3 fundamental steps: resection of a diseased segment of colon, typically near the rectosigmoid junction, closure of the rectal stump, and fashioning of an end colostomy. This is typically done in an emergency setting for indications such as acute complicated diverticulitis, malignant obstruction, ischemic colitis, among others. Hartmann reversal, on the other hand, is typically done in the elective setting with the aim to restore intestinal continuity. And then this is done by resecting the colostomy and performing a colorectal anastomosis. The reversal rates in the literature vary anywhere between 23 and 74%. As this is a quite morbid procedure, it's associated with a significant risk of complications and mortality. One of the complications that we know of is that some patients go on to require reoperation, among others, for recreation of a stoma. So we wanted to look at the rate of patients who undergo this entire ordeal only to end up with a stoma anyway. Our objective was to identify predictors of reoperation for recreation of an ostomy following Hartmann reversal. And so our primary outcome was the rate, as well as the predictors of reoperation for a new stoma, and secondary outcomes included postoperative outcomes. This was a retrospective cohort study in which we used data obtained from the American College of Surgeons NSQIP database between the years 2012 and 2020. We included all adults who had undergone elective Hartmann reversal between those years, and excluded any patient who was severely or critically ill at the time of the procedure, or for which the procedure was done in an emergency setting, which is quite atypical. We had a total of 15,147 patients, of which 14,824 met inclusion criteria. And what we found was that 5% of patients undergoing a Hartmann reversal in an elective setting require a reoperation in the postoperative period, of which 1/5 are done for recreation of an ostomy. On univariate analysis, we found that patients who required a new stoma after Hartmann reversal were more likely to have a higher Charlson comorbidity index, to be immunocompromised, have a higher ASA class, have had undergone an open approach as opposed to a minimally invasive approach, and have required blood transfusion during their Hartmann reversal. On regression analysis, we found the 4 following to be predictors of requiring a new stoma after Hartmann reversal. So increased Charlson comorbidity index, an open surgical approach as opposed to laparoscopic, an organ space infection in the postoperative setting, which we inferred to reflect the patients who had leaked, and postoperative sepsis or shock following the reversal. In terms of postoperative outcomes, we found that patients who required reoperation for a new ostomy had overall worse outcomes with a longer length of stay, a higher rate of 30-day complications, including but not limited to organ space infections, a significantly higher rate of 30-day visits to the emergency department and readmission, and significantly increased mortality rates when compared to patients who did not have a new ostomy after a reversal. So what we found was that, in summary, requiring reoperation for a redo ostomy is not an uncommon complication is not a rare, but it is an uncommon complication of a Hartmann reversal, and it represents 1/5 of all reoperations following a Hartmann reversal. Factors that affected patients who went on to require a new stoma included operative approach that the patients lended themselves to, their level of comorbidities reflected by their ASA class and their Charlson comorbidity index, and their immunosuppressed status. We also found that patients who had difficult operations or difficult postoperative courses were more likely to require the need for a redo ostomy after their Hartmann reversal, which prompted us to inquire whether these patients could be selected for in the preoperative setting in terms of planning for a potential diverting ileostomy or different operative approach at the time of consent for the procedure. Thank you.